Welcome back to the Explainer. Today, we're jumping straight into a super specialty review of Chapter 377, and we are focusing exclusively on the inflammatory myopathies. Now, if you regularly evaluate patients with muscle weakness, you already know that just lumping all these conditions together, it simply doesn't cut it anymore. So we're going to totally upgrade your diagnostic toolkit today. We're taking it all the way from outward clinical symptoms right down to definitive microscopic muscle biopsies. We'll break down the clinical spectrum, those highly specific autoantibodies, and the histopathologic hallmarks that literally define these distinct diseases. Let's get into it. Here's our roadmap for today. We'll start by meeting the myopathies, then dive into dermatomyositis, polymyositis, and necrotizing myopathy, tackle the anti-synthetase syndrome, and finally wrap up with inclusion body myositis.
All right, Section 1, meet the inflammatory myopathies.
To really grasp this, we first need to completely compartmentalize these 5 distinct clinical entities. Grouping them under a single umbrella term is just a recipe for misdiagnosis and poor management. So let's separate them right out of the gate to prevent any cognitive overload. Look at this demographic and clinical split here. You've got dermatomyositis and polymyositis, which typically present with symmetric proximal weakness and highly elevated creatine kinase, or CK levels. But then, check out inclusion body myositis, or IBM, right down at the bottom. IBM uniquely affects older adults. We're talking mostly men over 50. And it presents with proximal and distal, often asymmetric weakness, and get this, totally normal or maybe just mildly elevated CK levels. Setting up this mental matrix, that is your absolute first step to mastering these myopathies. Moving right along to Section 2, dermatomyositis, looking at both the skin and the muscle. Let's start with the visible stuff to kind of visually anchor these classic features before we get to the hidden microscopic damage. Notice the V sign on the anterior neck and the shawl sign draped over the posterior shoulders. These are macular erythema plaques, and they're really driven by sun exposure. Now, looking at the hands, we see the absolute hallmark, Gautron papules. These are those raised erythematous rashes specifically over the knuckles, alongside the Gautron sign on the extensor surfaces of the elbows. Oh, and you definitely don't want to overlook those dilated nail fold capillaries. They are highly, highly diagnostic. And remember, these skin symptoms aren't just cosmetic, right? The severe pruritus alone can literally ruin a patient's quality of life. Okay, so here's the real game changer. Identifying the specific autoantibody directly predicts your patient's clinical associations and their underlying risks. Saying it's dermatomyositis just isn't enough anymore. If your patient has anti-MI2 antibodies, they often have a really florid rash, but actually a great prognosis and response to therapy. But on the flip side, if you spot anti-TIF1 gamma or anti-NXP2, your radar for underlying adult cancer needs to immediately go off. And if you see anti-MDA5, wow, you really have to be careful. This one is often associated with amyopathic DM, meaning almost no muscle involvement, but it comes with a terrifyingly rapid and progressive interstitial lung disease. Finding these specific antibodies is exactly what dictates whether you just lean on standard corticosteroids or if you need to immediately escalate to aggressive second-line immunosuppressants. Now, looking under the microscope, we see the absolute hallmark of dermatomyositis. See how the muscle fibers on the outer edge of the fascicle are shrunken. That is your classic perifascicular atrophy. And right alongside that, you'll see this dark brown staining, which indicates a striking MXA overexpression. This finding is huge for our understanding of how DM works. It confirms that dermatomyositis is actually primarily driven by type I interferon-mediated toxicity, specifically IFN-beta, rather than just a simple antibody attack and complement-mediated destruction of capillaries like we used to think. This specific mechanism is exactly why emerging trials for IFN beta blockers and JAK inhibitors are showing so much promise right now. All right, let's pivot to Section 3, polymyositis and necrotizing myopathy. We really need to do a high-yield contrast here. Historically, polymyositis and immune-mediated necrotizing myopathy, or IMNM, were mixed up all the time, with tons of IMNM cases being misdiagnosed as PM. Getting this juxtaposition right is absolutely critical for your diagnostic accuracy. True polymyositis is actually quite rare, and it's characterized by heavy CD8 plus T cell infiltration around non-necrotic muscle fibers. In stark contrast to that, IMNM is defined by exactly what its name implies, severe muscle necrosis, shockingly high CK levels, we're talking often more than 10 times the upper limit of normal, and a super conspicuous lack of primary inflammatory cells. Take a look at the presentation of a true polymyositis biopsy. Look really closely at those pink muscle fibers. Notice how they're perfectly intact? They are not necrotic at all. Yet, they are just intimately surrounded and invaded by those dark purple inflammatory infiltrates, mostly CD8+ T cells and macrophages. You'll also see a really ubiquitous expression of MHC1 on these fibers if you happen to stain for it. Now, contrast that with INMM right here. It is literally night and day. You can clearly see muscle fibers in a state of multifocal necrosis. They look pale, they're fragmented, they're undergoing phagocytosis. But look around them. Where are the cells? Those robust inflammatory T-cell infiltrates we just saw in polymyositis are nowhere to be found. It is a completely posse-immune necrosis. Clinically speaking, when you suspect IMNM, you absolutely must test for these specific autoantibodies. First, anti-HMGCR. This can actually be triggered by statin use, especially in patients over 50. But here's the catch. Unlike a standard toxic statin myopathy, anti-HMGCR IMNM does not just go away by stopping the statin. The good news? It responds incredibly well to IVIG monotherapy. On the other hand, if you find anti-SRP antibodies, well, buckle up. This form is notoriously aggressive, subacute, and so often refractory to standard corticosteroids, meaning you're going to need some heavy multi-agent immunosuppression. Next up, Section 4, the anti-synthesitis syndrome. This one used to just get lumped in as a subset of DERPS or polymyositis. But ASyS is now rightfully recognized as its very own distinct beast. The presentation here is a highly specific constellation of symptoms. You are looking for myositis paired with interstitial lung disease, non-erosive inflammatory arthritis, Raynaud's phenomenon, fever, and those classic mechanics hands, that rough, cracked skin on the sides of the fingers. Seeing these manifestations alongside aminoacyl tRNA synthase antibodies, like anti-Jo1, signals ASyS. And because that interstitial lung disease can be so severe and life-threatening, recognizing this entire constellation early is vital. Early aggressive treatment, often with rituximab, is absolutely crucial for managing that lung involvement. Under the microscope, ASyS completely reveals its unique identity. Unlike the perivascular atrophy we saw back in classic dermatomyositis, ASyS actually shows perivascular necrosis. And even more distinct than that is the damage to the perimysium, that's the connective tissue surrounding the muscle fascicles. You are going to see perimysial fragmentation and a highly specific alkaline phosphatase staining. It's also driven much more by gamma interferon than type 1 interferon, making it pathologically entirely distinct from DM. And finally, Section 5, inclusion body myositis. Let's explore the real odd one out of the group. IBM is actually the most common cause of myopathy in patients over the age of 50, but it is notoriously misdiagnosed. So let me pose a quick question to you. If you see a male patient over 50 walking in with progressive asymmetric weakness and their CK levels are totally normal, what should you immediately be thinking about? The answer every time should be inclusion body myositis. The clinical pattern of IBM is just incredibly specific and honestly quite fascinating. Unlike the other myopathies we've talked about today that are purely proximal, IBM causes both proximal and distal weakness. It has this striking predilection for the deep finger and wrist flexors, which leads to a major loss of grip strength, and the quadriceps, leading to knee buckling and falls. Dysphagia is also super common here. Notably, unlike DM or PM, there's no known increased risk of malignancy with IBM, but it is unrelenting. The mean duration from the onset of symptoms to needing a wheelchair is sadly about 15 years. When you look at a muscle biopsy in IBM, you see a truly fascinating mix of autoimmune inflammation sitting right alongside neurodegenerative-like features. You'll see endomysial CD8+ T cells attacking the muscle, kind of like PM. But look a little closer and you'll find rimmed vacuoles and COX-negative fibers, which indicates mitochondrial dysfunction. And most amazingly, you'll see the aggregation of proteins like P62 and the really unique extrusion of the RNA-binding protein TDP43 from the myonuclei out into the cytoplasm. That's a feature it actually shares with neurodegenerative diseases like ALS and frontotemporal dementia. As we wrap up this explainer, I want to leave you with something to really think about. Ask yourself, how is mapping these distinct clinical, serological, and pathological triads going to alter your management strategy for your very next patient? Whether it's screening an anti-TIV1 gamma patient for cancer, treating an anti-HMGCR patient with IVIG, or avoiding heavy immunosuppression in a neurodegenerative-leaning IBM patient, precision diagnosis isn't just an academic exercise anymore. It is literally life-saving. Thanks so much for joining me on this deep dive. Keep examining those slides and keep questioning the detail.